Hello everyone and welcome to our live session today. I will be going over a quick startup presentation to welcome you all and introduce you to our program and the various opportunities if you have not, of course, previously attended any of our shadowing sessions. I do want to highlight that Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter the demographic status, abilities, or location. My name is Jesus. I am the Chief of Program Planning here at PHS, and I want to thank you all for attending today. So now let's get started. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen, and if you need assistance enabling the transcript, please direct message one of our team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations whatsoever for how we can improve, you can definitely email us at info@prehealthshadowing.com. So, since this is an international program, we do want to know where are you guys Zooming from today? You can drop it in the chat so we have a good idea of where you guys are coming from. I can see, okay, thank you guys so much. So we do have people from all over. Thank you guys so much. I myself am calling in from the wonderful island of Puerto Rico in the Caribbean. If you want to stay in the loop, you can follow us on social media. We are active on both Instagram and TikTok, and you can also sign up for our email list on our website to never miss a session. And we do have some wonderful opportunities for you all as benefits of being part of our program. If you were by any chance looking to get research experience, I am excited to announce that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research in a variety of topics, fields, and locations. Oh, I am sorry. Seems like I was muted. Oh, there we go. Okay, I'm really sorry, guys. There we go. Okay, wonderful. As I was saying, the program is 100% remote, which means you have the power to connect with absolutely anyone. This is an 8-week program that will begin on June 21st, so really soon. For more information, you can fill out the interest form that was sent in the chat below, and we will definitely get back to you as soon as possible with any additional details. We have also partnered with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources, such as study guides to help you prepare for your standardized tests like the MCAT, the NCLEX, or the PCAT. If you fill out the short survey in the chat, we will definitely get you signed up for these for free. And we would also like to draw your attention to another amazing program, that being NeoLive. NeoLive is an online mental health platform for students, for pre-health professionals especially. We know that the path isn't easy, so that is why we have partnered with NeoLive to spread the word and offer free access to their services if you use the link in the chat or enter the code PREHEALTH when signing up. Additionally, we are really excited to announce that we have partnered up with Krispy Kreme for you to purchase one delicious dozen donuts to enjoy with your loved ones. With a donation of $10, you'll be able to receive your treat while also helping us here at PHS. More information and instructions can be found by clicking the link that was sent in the chat. Mask for Mask is another amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic, for example, those in the homeless community, healthcare workers without their proper PPE, and others who are struggling to stay safe. With our discount code PHS15, you can get 15% off your order. And if you buy through this method, pre-health shadowing will also get 10% of the proceeds, which is amazing because, as I mentioned earlier, we are a nonprofit that runs solely off the support of our community. If by any chance you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and a lot more. We understand that as a pre-health student, you of course may not have the time. So we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would definitely love to have you be part of this program and contribute your own unique perspective. Also, very good news, if you are a high school student and you want to get involved, we have also started a program called HTP, or High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students that are interested in medicine through pre-health shadowing. Here at PHS, we want to recognize the hard work of all of our students in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief and through the link that was dropped in the chat to have your work on our website. These will definitely look great on CVs, applications, resumes, etc. So do take advantage of it. Part of our mission at PHS is to promote diversity. And in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and International Student Forum. If you have a mentor, professor, or professional that has inspired you in any way, and you think they could contribute to these conversations, please nominate them using the link that was dropped in the chat. If you can, we humbly ask that you donate to our program. As you all know, pre-health shadowing is completely student run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. Throughout the session today, we encourage you all to drop any questions you may have for the speaker in the chat. Our team members will be making note of these to be asked in the latter half of the session, that being the Q&A session for this live session. We also encourage you all to take good notes as our professional is going over their presentation, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available at the end of the session, so stay tuned. Lastly, if you can, we request you turn your cameras on. This is by no means an obligation, as we are respectful of different circumstances, but it does help us feel closer together in a time when socially distancing is mandatory. And we also request that you make sure to mute yourself, as this will ensure the professional has the complete and full attention from the audience. I appreciate you all for listening. And now I would like to welcome our professional, Dr. Chan. Thank you so much for joining us today. She did ask for us to share a little polling questions right before we begin. So you may share your screen, Dr. Chan, while we share the polling questions.
All right. Are you able to see my screen here?
Yes.
Okay. Should I get started with the session, or should I give some time for the polling questions? What do you think?
I'll be, putting up the polls, and you can just wait a little over a minute maybe, so we have all the students, or as many students as possible answering the polling questions. Okay, we're already getting some answers. I believe we can wait a little, 10 more seconds, and then we can definitely begin with our session. Wonderful. Okay, I see lots of participation, which is great. Okay, so I will be closing the polling questions in 3, 2, 1, and the polling. Here are the results, Dr. Chan.
Okay. Let's take a look here. And you'll be able to save this for me, right? So I can look at this kind of at the end. Let's see here. Excellent. All right, everyone. Well, time to introduce myself. My name is Tiff. I am an academic breast radiologist. I'm going to talk to you guys a little bit today about a few different things. In general, I'm just going to be talking about what it's like to be a radiologist, and I'll go over some cases as well. I'll start off, I have a few goals for you today. I'm going to share first a little bit about myself and the journey I took to get to where I am today. I want to give you a little bit about the background in radiology and what kind of field it is to begin with. I will also show you kind of a typical day in my life and give you an introduction to a few different types of imaging that we deal with, including current screening mammography guidelines. And lastly, I'll show you some cases as well, some real patient cases. So I can kind of show you pathology, some disease processes, and some of the procedures that I do as well too. So let's start off with a little bit of introduction. I'm currently an attending physician on faculty at UCLA, an academic hospital. I'm considered part of the junior faculty because I've been doing this for about 2 years, and I actually just completed my fellowship in this in 2019 from the same place at UCLA. So in the pink here, you can see that this is kind of my journey to getting to where I am today. I'm one of the less common people to have just gone through everything without taking any gap years or any years off. Ironically or interestingly, I was in the minority in that sense. Most of the people that I went to medical school with had actually taken some time off, whether it's research years, post-bac. I had a friend who actually did a completely different career. She was in banking, and then kind of realized that she, wanted to do a different path. So then she applied to medical school. In my case, I went straight through, and you can kind of see all the things that I did here. One thing that I do want to, point out is that if you want to become a radiologist, you do something called an intern year. This is the year right after medical school. Is our general year. So you don't really do much radiology then. You can choose between medicine, surgery, or a combination of both. And then you kind of do years dedicated to radiology. I personally chose to do a year in surgery, which I felt like was really good for procedural skills. A lot of surgeons read imaging, so I probably was exposed to more radiology in that sense. And overall, I felt like it was a really good way to kind of hone my efficiency skills, as you can imagine. So that's, kind of my path. Let me go a little bit into what exactly radiology is. I'm not sure if you guys have had many sessions on it. So essentially radiology is this really cool field that almost every other specialty depends on. From primary care to neurosurgery, all doctors rely on medical imaging in some way to help them make decisions for their patients. Now, we're not covered on a lot of medical shows. And when we are, usually it's someone who is not a radiologist holding a picture that's upside down or, backwards or something. And while many physicians are kind of okay at reading their own specialties imaging, let's say orthopedic surgeons and knee MRIs, it's always our responsibility to know more than them about their imaging and to pick up on extremely unusual or subtle, or also just as importantly, acute findings. Radiology is basically reframing everything that you will learn in medical school in the form of pictures. And so these pictures include X-rays, MRIs, CT, PET scans, angiograms, mammograms. These are all the different types of things that you may have heard of at some point in your life, somewhere, somehow. And at the end of the day, the best parts, or what I really like about radiology, is that images present the truth about a patient. Patients can lie, histories can be faulty. You may have a patient who came in a car crash and literally cannot say anything. But imaging is going to tell you the answer about what's happening inside that patient. Another thing I really like about radiology too is that we're staying on top of the latest technology. So as medical technology advances, radiology also advances. So for instance, a lot of older radiologists were trained primarily on X-ray and ultrasound, which are the more like old school sort of techniques. And of course, now we have what we call cross-sectional imaging, which is CT and MRI. So there's always kind of new things that are happening on the horizon, and being a radiologist means that we kind of get exposed to that. And so this chart here is kind of showing all the different specialties within radiology. All of us have done a residency in radiology, and we've rotated through all of these sections. Most of us nowadays will do an additional year or maybe even two in one of these specialties. And I just kind of listed, examples of some common studies that are read. In my case, I did a specialty in breast imaging. So mammography is one of like the three-ish sort of types of studies that we read. Interventional radiology is the only one that's a little bit more different, or IR. Now they're kind of going on a path where they're more integrated, but that's for an interventional radiologist to talk about. There are some myths about radiology that you may have heard of, and I certainly want to talk about it. So some people may think that radiologists are not real doctors because we're not like running down a hallway and shouting clear. But ironically, we are the only group that's considered the doctor's doctor, meaning that we are the ones that get consulted from other doctors about our opinions on their patient's imaging. And depending on the specialty, such as my specialty, breast imaging or IR, we actually have our own patients as well too. And I'll kind of go into a little bit about that. There was one kind of interesting myth saying that radiologists don't like to socialize. The ironic part, of course, is that, our hours overall are not too bad. So we have more time to socialize outside of the hospital. And certainly radiology is not easy. It's actually one of the toughest fields because we do need to know everything medicine-wise from head to toe. So even though I, specialize in breast, at some point I had to read things about the brain, about the ankle, abdomen, so all that sort of stuff. It's a lot of information, and you have to be able to really understand it for sure. We have to know anatomy, we have to know disease processes, and then also kind of just as importantly, we need to know what we call normal variants, which makes up basically a small proportion of the population, but it's technically normal and does not need any further intervention. So that's kind of the three categories of things that we have to deal with. Our board exams are one of the toughest. It's 2 days long and I think it used to be 16 hours total, although I think they're revamping it now. This is just like a very general sort of slide about the things that are useful if you wanted to get into radiology. Obviously, step 1 and step 2, or at least step 1, they're kind of changing, but just so you have an idea, above average board scores were necessary for matching into what we call diagnostic radiology residency. Almost 20% are AOA members. A lot of us are interested in doing research. Once you get the interview, of course, there are some other things that are also very important: interpersonal skills, interactions, things that I would argue are important in any job that you do. But this is just kind of some things to think about. You may have heard of the road to success. This is traditionally the 4 fields that give the best compensation and lifestyle, aka your work-life balance. Now, remember that compensation is only part of the overall lifestyle, okay? But I bring it up only because it's not really discussed among pre-meds or med students, and it really does have a practical significance. I had about $300,000 in loans, including college through fellowship. I'm still paying them off today. But in general, if you look at this table to the right, radiology doesn't do too bad in the grand scheme of things. The most important thing that I want to draw your guys' attention to is probably the bottom left graph. I would choose the same specialty. And these are all tables from, I believe it's Medscape. They did like a survey. And as you can see, radiology is pretty high up there in the number of people that would choose that same specialty again all over. So just some things to think about when you're talking about radiology. So let's talk about what I do, a typical day for me. So breast imaging is a specialized field of radiology. It's dedicated to the diagnosis and management of breast pathologies. We use things like mammogram, ultrasound, and MRI to evaluate patients. And we also actually do interventional procedures. So we do things like biopsies, and everything is done under imaging guidance here. So here you see a picture of me doing a breast biopsy under ultrasound guidance. That's what that screen over there on the left is for. Obviously, we need imaging guidance to accurately get to where we need to go, and also to avoid important structures such as blood vessels, because we don't want people to bleed. This is an example of a mammogram in case you've never seen one, and I'll kind of go over what is happening in this picture. And at the bottom is a picture of a breast MRI, and I'll go over that as well too. So I chose breast radiology because I feel very fulfilled seeing patients, and my ideal job was always going to be a mix of both imaging and direct patient care. And most importantly, I really like doing procedures. So I was drawn to IR, I was drawn to surgery, all those things during medical school. And it could be because I played video games when I was younger. I'm not really sure, but certainly hand-eye coordination and that sort of thing was always something that I liked being challenged by and getting better at. So I found a field that I think fit my personality, so that my day goes by faster and I can go home at the end of the day feeling that I've really done something for patients. So what exactly do we do? So we work in our own clinics, which is a little bit different than other radiology fields. Of course, we spend some time in a dark room. And by the way, radiologists have a dark sort of room so that the eye can better see contrast and subtleties in imaging rather than in just a normal lit room. But that's really only 30% of my day. The majority of my day is actually spent discussing findings and recommendations with patients, which is also different from other radiology fields. I do a lot of image guided procedures every day as well. Biopsies, I kind of mentioned a little bit about. Abscess drainages we do, cyst aspirations, and something called pre-surgery localizations. This is kind of my general schedule for a day. This is an average day. Basically, it's a mix of procedures, what we call diagnostic studies, and I'll go over that as well, and reading screening studies, and both mammograms and MRIs as well too. So being in academics, as opposed to private practice, which is kind of like your other category, I also teach residents and fellows every day. They're on service with me, and I kind of teach them all the things that I'm teaching you guys now. I also am in charge of giving about 1 to 2 lectures, every 3 to 4 months. I work very closely in the resident curriculum, so I'm always thinking of ways of improving resident education, thinking of innovative ways to teach skills. So if you see this picture on the right, this is actually a new synthetic breast model that I'm kind of testing out. And this is the way that I want my residents to learn how to do a biopsy before they do it on a real patient. They need to learn hand-eye coordination. They just need to know how the equipment feels, how it works, their positioning, everything like that. I want to get, ironed down before they do it on a real patient. Okay, so this is kind of an example of a way that we're teaching our medical trainees. On top of that, also, I'm always writing up papers, doing projects, with the ultimate goal of journal publications and going to conferences. So our patients, by the way, are mostly women. They're of all ages, generally, above 14 years old. And I've actually seen 98-year-old patients as well, too. But interestingly, we also see men. So when we think breast, we usually think women, but actually we see probably 1 male patient a day at the very minimum, because men can get lumps and they can get pain in their chest. And interestingly, men can actually still get breast cancer. You don't hear about it very often, but male breast cancer, makes up about 1% of all breast cancers. It's still a very real thing. And it's something that we never want to miss if somebody like a male has a new lump. More common things that we rule out or that we're actually happy to rule out because it's not a cancer are things like gynecomastia, which is benign breast tissue, and things like lipomas, which are benign fat tumors. These all give the sensation of a lump, which is what your physical exam is really important for. But you're not going to be able to do much beyond that if you don't have imaging. And so that's another way that radiology can help kind of show you what that lump is and if it's good or bad. So that really helps out. Let me talk to you a little bit about what we do in our clinic. So we technically divide our patients into one of three categories: diagnostic, screening, and procedure. So I'll first discuss diagnostic and screening. Essentially, diagnostic patients are those that are coming in with a specific issue, whether it's a symptom that they're presenting with, a follow-up of a previously evaluated problem, or what we call a callback from screening. So one of these three rectangular boxes up top. And a callback from screening, by the way, is basically when somebody has undergone screening and something abnormal is seen on their mammogram and we need to kind of evaluate it further. Basically, all of our diagnostic patients are going to get some additional imaging with us. That's in the orange box. And that can be a mammogram and or ultrasound. It depends on their age and finding. There's a whole set of guidelines that I'll go over with you about that. After we kind of evaluate these issues a little bit more closely in our clinic, then we have to decide on the management. That's my little purple think bubble here. So when we're deciding on management, we have a few choices. We can say, hey, everything actually looks okay. You are fine. There's no cancer. Come back in a year for your next screening exam. We may ask to do a follow-up in, let's say, 6 months, just to make sure nothing's changed. We may have a more concerning conversation where we say, hey, we need to get a biopsy, meaning we need to get a tissue sample of a suspicious area to make sure that it's not cancer. And sometimes we may say, hey, we need to actually get an MRI. So after we make this decision, we actually go and we discuss this with the patient as well, too. And it can be very difficult conversations for sure. I think the most important thing in my experience is just being a good communicator, setting realistic expectations, and also obviously being very empathetic. This is a very scary situation for many patients. I mean, in breast imaging in general can cause a lot of anxiety. People, I mean, that's one of the reasons why people don't even want to get screening mammograms. So it's important that people have a good experience with us so that they can continue to get imaging, which helps catch cancers early on. On the other side of the screen, in the pink dotted line, that's our screening group. So screening groups for breast imaging is the same as any other part of the body, whether it's a screening colonoscopy or whatever. These are patients who are asymptomatic, meaning they have no symptoms at all, but they meet a certain threshold. Let's say that they are 40 years old, which is our cutoff by the ACR guidelines. And that means that they're coming in and they otherwise would have no suspicion that they have a cancer. This is important because this is the group of people that we want to catch cancers in when they are small and when they're in their early stages, okay? And I'll go over a little bit about screening as well too. So at this point, you might be wondering, like, what are even some breast pathologies? So chances are you've probably heard of breast cancer and maybe cysts and not much else. So this is just a very brief overview of all the things we deal with. And of course, I can't go into each and every one of them, but it's just kind of to show you the things that, you know, we see in the breast. There's a few things that I think anybody should know, whether you're a radiologist, a doctor, a whatever, or even going into medicine at whatever stage you are. First of all, you cannot tell if a breast mass is benign or malignant by physical exam, okay? What I'm saying is that just because something happens to feel a little bit harder or like more squishy or more mobile, none of those things should be reassuring to you. You just don't know what it is. The most important thing you can do is to recognize that you have a mass and to come and get some imaging done. The imaging is going to tell you whether it's something suspicious or not. Some other tidbits that I think you should know. The most common type of breast cancer is called invasive ductal carcinoma. So you're going to hear us refer to that a lot. It's called IDC. DCIS, or ductal carcinoma in situ, is also considered to be a breast cancer and is treated as such. And then lastly, there are also other things that happen to the breast as well too. There are cancers that happen elsewhere and metastasize to the breast. So things like lymphoma, melanoma, lung cancer, some soft tissue cancers. So there's some crazy stuff that can metastasize to the breast, and we've seen pretty much all of it. So that really does happen. So let's talk a little bit about screening mammography. I kind of was promising this. You may have seen some different guidelines in the news, but we go by the ACR or American College of Radiology guidelines because we're radiologists, and we're the ones who actually see and pick up the cancer. So the general premise, like I said, is that we want to reduce mortality from cancer, and we do that by detecting asymptomatic cancers. Obviously, if a cancer is advanced enough that a patient can feel it, we are still going to take care of that. But we ideally want to find it when it's small and not causing any issues. So basically, the recommendation for the regular asymptomatic women in the US with average breast cancer risk, we recommend yearly mammograms starting at age 40. Interestingly, there's no end age because we do see very healthy, let's say 88-year-olds with no other medical issues. So these people would benefit greatly if we were to catch a breast cancer. So it kind of, at the later part of your years, it matters more if you would be able to, withstand, let's say, chemotherapy, surgery, whatever. If you are super healthy and it would really benefit you, then we still recommend getting screening mammograms, if that makes sense. I've also included some statements here from the ACR about varying screening recommendations from other organizations, American Cancer Society and the US Preventative Services Task Force. The problem in general is that if you delay mammograms until even 45 or 50, you're missing a lot of cancers that do present in the 40s. So that's kind of why we say start at 40. Now, I said that was for all average risk women. There are high risk women as well, too. And this means that you have a calculated lifetime risk of greater than 20%. That model, there's actually different models that help, determine this percentage, and you can kind of Google them online as well, too. People who have had chest radiation for, let's say, other types of cancers when they were younger, they are also at higher risk because chest radiation can increase, the chance of cancer, basically. In high-risk women, we have a different recommendation. We want yearly mammograms starting at 30 and yearly breast MRIs starting at 25 to 30. And most importantly, all women, especially these two groups, should have their risk evaluated by age 30. So you should know kind of where you stand. What happens after screening mammography? Well, if you have 100 people who go and get their screening mammogram, about 90 will have normal mammograms. We will say, come back in a year for your next one. 10 would be what we do a callback for. And out of those, 6 will still be reassured that their mammograms are normal. Sometimes we just need some additional images, really focus on specific areas that just kind of look funky on their mammogram. 2 are going to be asked to return in 6 months for a follow-up exam. That means that we have a slight suspicion, but it's nothing too concerning quite yet. And then out of the 102 will be recommended to have an actual biopsy. So it's kind of just an idea of how frequently we're kind of recommending these things. So let me talk a little bit about the different types of imaging modalities that we deal with. A mammogram is basically an X-ray of the breast. X-rays are the oldest and most commonly used form of medical imaging. And essentially, they allow us to see inside the body at a tiny, tiny cost of radiation. So each mammogram, a screening mammogram, has essentially 2 views that we are seeing. It's called the CC or craniocaudal view. Craniocaudal means from like head to tail. So I'll go over a little bit what that looks like. And also the MLO view, which is the medial lateral oblique view. Diagnostic mammography, aka when somebody has, like, let's say a lump somewhere, it's going to have different variable types of mammograms that, I'll go into as well too. This picture is the mammogram machine. This tube, it looks like this. Basically, your breast is going to go where that black square is, and there's going to be a little plastic paddle on top that kind of goes down like this. X-rays are coming from the top, going all the way down to the bottom. If you can see my hand, I don't even know if you can. Yeah, there we go. From the top down to the bottom. And that's how we basically get a mammogram. So let's take a look at how we even interpret a mammogram. So in order to look at what a CC image is, this is how I best visualize it. So on the right side, I'm going to label each one of these. So this is going to be your right breast. This is going to be your left breast. To best visualize how to look at this, I would say to kind of look down at your own feet. So if you look at this cartoon woman here, and we're looking at her right breast, let's say, on the top of the picture is going to be where her right arm is. At the bottom of her picture is going to be actually where her medial breast is, or where her sternum is. You kind of flip for the other way as well too. Top of the picture is going to be the left arm for that left breast, and the bottom part of the picture is going to be your sternum. Okay, so it's kind of confusing when you first start off. Let me go over some basic anatomy, what we can see here. Again, like I said, the lateral part of your body is going to be away, which is going to be where your arms are, the top of the pictures. And along the medial aspect is going to be the midline, or where your sternum is. And I've also drawn out some things here. Obviously, you can see nipple right in the middle. And at the back, you might be able to see kind of like this white fuzzy thing here. That's actually part of your pectoralis major muscle. So that's the muscle that goes across your chest. We see it better on the other view. So don't worry about that. I'm going to start telling you guys that when we look at mammograms, white is going to be our normal fibroglandular tissue. All the stuff that what we call is black, it's really gray, but the rest of it's fat, okay? The reason why that's important is because cancer comes from tissue. It does not come from fat. So whenever cancer is actually present, it's going to be white. So essentially, when I'm looking at a mammogram and trying to read it and make sure there's no cancer, I'm looking for an abnormal spot of white in a sea of white and black. There are fat-containing masses, such as lipomas, and those things are going to appear black or gray. So it all kind of makes sense. Let's talk a little bit about the MLO view. This view, I think, is a little bit easier to understand. It does include more breast tissue than the other view. Superior, where the top of is where your clavicles, your neck, your head are. And then underneath is going to be your inframammary folds and your upper abdomen. So I kind of annotated this for you here. You can see your pectoralis major muscle much better here. If we were doing a mammogram on a guy, which we do, the pec muscle is going to be much, much bigger, and there's going to be much less breast tissue. You might also notice these kind of small white ovals in the back. What are those? Those are lymph nodes in your armpit or in your axilla. So we get a very good look at these lymph nodes on mammograms. It's actually very relevant now, especially in the time of COVID vaccinations, because COVID vaccinations actually can cause your lymph nodes in your axilla to get bigger. It's usually on the same side. So if you get, let's say, your shot on your left arm and you feel some, lumpy bumpiness in your armpit, a few days afterwards, chances are you have something called reactive lymph nodes. It's a completely normal reaction. It actually happens with flu vaccines as well. Anytime that you are kind of inflaming something. So if you were to get, let's say, a tattoo on your left arm, or you had an infection on your left arm, all of those things are going to make your lymph nodes bigger. The reason why we care about lymph nodes is because they can sometimes be a sign of breast cancer. Breast cancer, if it's present, can sometimes go to those lymph nodes as well. So it's always important for us to kind of differentiate between the two. Of course, lymphoma, is a disease of the lymph nodes, and we can actually catch lymphomas on breast mammograms as well too. So that's also something interesting. Let's kind of go back and talk about, the white and black part of our mammogram. So you may have heard of this kind of term, that breast tissue density. What does that mean? So density is basically the ratio between tissue and fat, between the white and the black. And we classify breast density using 4 different categories. So one of the more important things I want you guys to remember is that breast tissue density is not determined by physical exam. You are not going to know your breast tissue density. Your OBGYN is not going to know. Your family med's not going to know. No one's going to know except your radiologist, because it's something that's categorized by mammogram. You can fall in one of 4 categories. And in the green, I have the percentage of the general population. So most people, 80% of people, are going to be right in the middle. They're going to be one of these 2 middle categories. You can be 10% as well too, where you're going to be mostly fatty, less tissue, or you can be extremely dense, where you have more tissue and less fat. In general, density is related to genetics, not necessarily to size as one may think. And it's also related to age as well too. So people tend to start off with more tissue when they're young. And as they get older, things get replaced by fat. There are some other things that may also increase your tissue density, such as hormone replacement or breastfeeding. And interestingly, if you gain weight, that sometimes can decrease your density because you're increasing the amount of fat in your breast. So ratio number-wise, you're just going to be less dense if you end up gaining weight and you gain weight in your breast. So why do we even care about breast tissue density in the first place? So remember that tissue is white and fat is black. Cancer comes from tissue, not fat. So remember that cancer is also going to be white on mammogram. If something is denser, it's going to be more white in general, and it's going to be harder to see those cancers. So let's take a look at this first panel here. So if I, the radiologist, am looking for something abnormally white on this mammogram, on this particular person's mammogram, it's probably going to stand out, right? Let's look at this middle panel. This is a different patient. This is a patient with dense breasts. There's a lot more white in this picture, right? Can I see something as abnormally white as easily? No, it's a lot harder. And I can show you exactly where it is, but it's definitely a little bit harder. So the issue is that people with denser breasts, number one, tend to have a higher risk of developing breast cancer, number one. And number two, their mammograms are going to be tougher for us to read. They are still very useful, okay, but it is going to be a little bit more difficult. There's some ways around it, but just so you know, that's why breast tissue density even matters to begin with. Let's talk a little bit about ultrasound. So I'm not sure how much you guys know about ultrasound, but this is one of the more old school sort of modalities. It's been around forever. And it still is here because it's a great modality. The best part is it has no radiation and it's very good for soft tissue in general. We use ultrasound for many things. We can use it for the fetal head. We can use it for the abdomen to look at gallbladders. We can look at soft tissues. I mean, one time I was worried that I had stepped in like some glass on my foot. And so I had an ultrasound to see if I could find any glass in my foot to make sure I was going to heal properly. So ultrasound is very useful. It is the first imaging test for women in our field under 30 who come in with a breast lump or pain. Mammography has radiation and it's less useful in dense tissue. And remember, younger women are going to have more dense tissue. So I'm not just coming up with this guideline. This is actually something called the ACR appropriateness criteria. This is useful for any physician, no matter what you're doing, because this is basically telling you on a scale of 1 to 9, with 9 being the highest, what is the most appropriate test for your clinical question. And if you go to this website, they talk about everything from, let's say, chest pain to vaginal bleeding. You basically have a patient coming in with a certain issue. You don't know what imaging to get. You go to this website and they'll give you the different ratings based on evidence-based guidelines. So in this case, we're talking about a palpable breast mass in a female that's younger than 30. Our initial evaluation is going to be the breast ultrasound. That's given a ranking of a 9. Less enthusiastic is going to be the mammography and MRI and all these other different modalities. So we start with breast ultrasound, okay? Just something to understand. Now, when we talk about breast ultrasound in our field, we scan the patient in the supine position. So supine means that you're basically on your back, kind of like pushing here. I think of soup like you're holding a cup of soup, very easy like this. The opposite is going to be prone, where you're lying on your belly. So when I show you this ultrasound picture, and that's what this is, you can kind of orient yourself. The top of the picture is going to be the front of the patient, where the ultrasound probe is placed. The bottom arrow is pointed to the back of the patient. So the patient is lying down on their back and we're scanning up top. The back of the patient is going to be the chest wall, the lungs, all these other things that we want to stay away from when we're doing a breast biopsy. We want to stay away from this area because we don't want the needle to go into the lung, which would cause a collapsed lung, which is also called a pneumothorax. So this is why imaging is very important for us, because we need to know exactly where our needle is going at all times. Lastly, before we go into actual cases, I'll talk to you guys briefly about breast MRI. So breast MRI is done in the opposite direction, what we call the prone direction. The breasts kind of hang through a window. And why do we do this kind of weird thing? So it's actually because we want to see all of the breast tissue on an MRI adequately. Whereas when you get a CT done, oftentimes you're on your back and the breast tissue is just kind of smushed down, right? So it's very hard to actually evaluate breast tissue on CTs. So everything we're doing is trying to maximize our ability to find the smallest abnormality on imaging. So who even needs a breast MRI? High-risk patients, patients with silicone implants. This is an example of an MRI with silicone implants in case you guys have never seen it before. They look very obvious on imaging, which is very interesting. And we often do breast MRIs for patients with biopsy-proven cancer, so people who already know that they have a cancer. But before they go to surgery, we need to know exactly if there's cancer elsewhere, if the cancer actually extends really far back, that sort of thing. And then, of course, breast MRIs are also useful in people who have had breast cancer and surgery, like years ago, let's say. But we're concerned that they have, let's say, residual disease or recurrent disease. Breast MRI is going to be the most sensitive for that particular question. One thing I also want to mention too is that breast MRI is the most expensive, obviously, out of all of these imaging studies. We don't offer it for every single person, not necessarily because of the price, but because it has a very high sensitivity to looking at even normal things, meaning we can pick up a lot of findings that don't end up being cancers. So in order to kind of do a risk benefit, sort of a good analysis, whereas we only want to biopsy things that have a high chance of being cancer. So we're not biopsying things left and right? We don't want to cause anxiety. We don't want to do unnecessary procedures. That's the reason why we don't do MRIs for everybody. And that's why we do mammogram, just so you guys know as well too. So let's start with some cases here. So this is an example of a mass. This is a 56-year-old female. She's feeling a mass on her right side, and it's marked by a BB. So this circle that I have here, this really bright white little dot, this is a little BB marker made out of metal. It's a sticker that our technologist actually plates on the person. So they say, hey, Mrs. Smith, like, where are you feeling this lump? And they point to the area, and our technologist will put a little sticker there so that when we take a picture, we can see exactly what she's pointing to. Metal or foreign bodies like metal are very, very bright on X-ray or on mammograms. So as you can see here, there's a clump of tissue that doesn't really look like the rest of the tissue, right? It's kind of like cloudy looking, kind of like clustered like this. The rest of the tissue is just kind of like that. So there's an area here that's a mass, and it actually is not too far away from what she's feeling. So I'm thinking that they're pretty much the same thing. All I can tell you, this is actually right superior mass, not left. But essentially there's a mass where she's feeling. The next step is to go to ultrasound. And as we can see, there's an irregular vascular mass. Now, vascular is important because cancers tend to be vascular. The whole way that tumors and things grow so abnormally is because they recruit blood vessels. They send out these molecules that recruit blood vessels, and there's angiogenesis. That basically means that they are kind of stealing oxygen and growing at an abnormal rate compared to other parts of the body. This picture on the bottom, this red stuff, it looks like it's on fire, but essentially it's a computer overlay that shows vascularity. It shows things that are moving. The only things that are going to be moving in this picture that are going to give the signal so the computer makes it red is going to be blood flow. So that's how I know that this is a vascular mass. All these things are very suspicious for cancer, so we are going to recommend a biopsy. And this came back as your classic invasive ductal carcinoma. This is a case that, obviously this person had presented to us with a lump. This is a classic case of a bad lump, but as I'm going to show you, not all lumps are bad. When we talk about masses, they're technically 3D space occupying structures. We look at their shape and their margins to determine how suspicious they are. So it's something like this, on the left, where it's more what we call circumscribed. You can kind of have a pencil, kind of draw a circle around it. It's not as concerning to me as the picture on my right. This guy has spiculated margins. He's got like crazy things going all over the place. That is a little bit more suspicious because cancers tend to look a little bit more like that. The reason why I want to talk about masses is because masses are not always bad. Obviously, no one wants to have a mass in their breast. It's a very scary sentence to even say. However, cysts, which are completely benign, they don't become cancers, and something called fibroadenomas, which is a benign breast mass, very common in young women. These are all considered masses. They can be felt, but they are not bad. They do not become cancers. That is why, we actually don't recommend specific guidelines for self-breast exams anymore. We used to, but I think the best way is to have patients kind of know how their breasts feel at baseline. So if that they're new lumps or pain or whatever, that's when they'll know to come in. The worst is when someone has no idea what their baseline is and they don't know how long something's been there. That's the most concerning part. Okay. So let's talk about, let's say, a good mass. So this is an 81-year-old female who's on anticoagulation. She had a stroke about a year ago, so she's on some medications that prevent her from clotting. A stroke, right, is going to be when some of the vessels in your brain clot, and then you're not getting blood flow, you're not getting oxygen to essential parts of your brain. Those people, once they, once they're treated, are going to be on medications that help thin their blood so that it prevents them from clotting again. Now, this person is coming in with a breast lump. She too is feeling something, and you can see that there's a big, dense white mass here on her left side. This is obviously abnormal. So you go and do an ultrasound, and the way that this looks, because of how ultrasound works, fluid and solid components look different. On an ultrasound, when something is a little bit more black, that signifies that there's some liquid in this mass. So it's very suspicious because cancers don't come from liquid usually. So what we can really do now is we can actually do what we call an aspiration. What we do is we give some local numbing medication, some lidocaine, and we insert a needle and a syringe into the mass and we take out what we can, if anything. And it actually turns out that we're getting this red, bloody, sort of gunky liquid. So this is actually a hematoma. A hematoma is a collection of blood. This is happening in this patient because she's on medication that thin her blood. So while this is protecting her from creating more clots, she's now going the other direction and is now bleeding more, okay? In a sense, you want to be able to clot when you can, okay? If you were to give yourself a paper cut or, God forbid, be in an accident or something, you want to be able to clot when you need to. Otherwise, you're going to lose all your blood, right? So that's the way I generally think of it. In this patient, this turns out to not be a cancer, but to be a hematoma. She didn't really remember if she had any trauma to this area, but these people need only a slight amount of trauma in order to even develop a hematoma, meaning she could have bumped herself when she was brushing her teeth or something, and this could possibly happen. She doesn't need to fall on herself in order for a hematoma to form. In a normal person with no anticoagulation, then yes, more trauma would be needed to create this hematoma. And if you did see this in a normal person, not an anticoagulation, you have to worry about a blood disorder that's making this person bleed more than they should. Okay. Let's go to another case. This is a 29-year-old female that's presenting with a left breast lump. So what is the first kind of imaging study that she should get? We talked about this before. She's 29, which is under 30. So she should be getting an ultrasound. And this is her ultrasound right over where her lump is. My question to you is, what is this thing? This looks like a mass, right? This looks like a cancer of some kind. Well, this is why our anatomy is actually really important. So that area that I circled is actually her rib. This is a totally normal structure. If I was to scan with the ultrasound machine a little bit to my left, I would see another one of these things. If I scan a little bit more to my right, I'm going to see another one of these things too. These are ribs, okay? So she's going to have multiple of them, and she's literally feeling her rib. This is pretty common actually in thin patients or patients without much breast tissue. It can be very concerning, but it's our job to make sure there's nothing in the actual breast. I've kind of marked off in different asterisks as well too, other things we're seeing. So the skin is going to be everything from this orange line and up. Breast tissue is going to be in blue, and that's where we're looking for masses, cysts, etc. It's a combination of gray and white because, like I said, there's tissue and there's fat. So there's different what we call echogenicities or different shades of gray on an ultrasound. This kind of black linear thing that's draping over the rib, that's your pectoralis muscle. So this is a very common look for any type of muscle in your body. That's how muscles look. They have that striated sort of look. Lastly, underneath the ribs, and remember Pusheen, she was like, that cat was like laying on like their back. So this is like the back of the patient, okay? The stuff that's marked in the yellow is going to be the lungs, all right? And actually during a real life ultrasound, you can see this area move up and down because the patient's breathing. We want to avoid going into this area, but it's kind of cool to see this person breathing. And that's where we want to not put needles in at all. All right, let's talk a little bit about calcifications. We talked about masses so far. So calcifications in the breast, let's first start off, are very common. It's calcium deposits in the breast. Calcifications are not unique to the breast. Obviously, they happen in other parts of the body. You may have heard of it happening in, let's say, your blood vessels, your aorta. Atherosclerotic calcifications can happen if you are a smoker, if you're older, if you got diabetes. This is a totally different group of calcifications. So they are usually asymptomatic unless they're very bulky, like they're associated with a mass or something, but generally by themselves, you would not be able to feel it. They don't cause pain. They don't cause a lump or anything like that. They actually look like bright white spots in the mammogram, and I'll show you some pictures. Why do we care? Well, calcifications can be good or bad. There's a whole spectrum of them. As radiologists, it's our job to look at their shape or their morphology and their distribution on mammogram. Some we look at and they're 100% benign. We don't even follow them. Others are very suspicious for cancer and need to be biopsied as soon as possible. And there's others that are in between and can be followed. So let me show you some examples here. So this is a 65-year-old who comes in for a screening mammogram, and you notice that there's all these crazy white lines like going everywhere. These are actually vascular calcifications. They are lining the wall of the blood vessel. the breast obviously had blood vessels, right? You need to get oxygen somewhere. They're curvilinear and tram track. So when I look at this, I know that this person has benign calcifications. It is not a cancer. All right. Now, if she was actually 41, it'd be very unusual to have so many vascular calcifications. If this was like her first medical study, I would have to raise the consideration of, let's say, is she an undiagnosed diabetic, undiagnosed renal failure? It's still benign in the cancer sense, but it can be an alarm, a red flag for something else that's happening in the body, a more systemic sort of issue. Because basically, when you're younger, you shouldn't be having calcifications like this. So let's put that in contrast with these calcifications. This is a 50-year-old who's presenting for a screening mammogram. I don't by any means expect you to know the differences in calcifications, but hopefully you can tell that this looks different than that tube sort of stuff that we were looking at before. This is an example of very suspicious calcifications. Their specific name is called a fine linear branching calcification. They're shaped like ducts, meaning that they are giving you the idea that they're growing inside a duct, like DCIS. These have a 51 to 95% chance of malignancy. When I see this on a mammogram, I have to make sure this patient comes back, and we eventually are going to have to do a biopsy as well too. This one biopsy came back as DCIS, which, by the way, like we said before, is a cancer. One interesting thing I also want to point out in my cases is implants. So I'm from LA, so let's talk about breast implants. We have a lot of patients with them. So there are two general types of breast implants. There's silicone and there's saline. So many patients with implants think that they shouldn't be getting mammograms. They're really worried that they're going to rupture. They think that it's not going to be useful. Nothing is farther from the truth. So if you have implants, our technologists are going to have special methods where they displace the implant during mammogram, okay? That way we can see the rest of the breast tissue where things are going to be happening if they are. Now, there's basically a 0% chance of rupture. I have never had it. I've never heard of it in my time working. I think there's some in the literature, but I'm suspecting that there were very, very old implants that were probably going to rupture with the patient doing anything. So it is not a risk. Mammography is not a risk for an implant rupture, and it's still very useful in these patients. I'll show you what one looks like in real life. This is a 760cc saline one. It's definitely on the bigger side, but there are different sizes, just so you know. And implants might make it harder for us to do biopsies, but we can still generally work around it. We're just going to be extra careful with those patients. So let's say that we have a patient who is worried about a rupture. She's having a lot of breast pain. She's got implants. She's not sure what's happening. So if we see here, there are actually, these are some saline implants that have rupture on mammogram. One thing I want to just point out to you guys, the difference between saline and silicone. So salines were, I believe, the more original breast implants. So they're older in their invention. If they're ruptured, you will be able to tell. The patient will be able to tell because one side is just going to be flat. Okay. If anybody has ever seen Orange is the New Black, there's an episode where like someone gets punched in the breast and like that one side just goes completely flat. Just by that story, I know that she had a saline implant. Okay. If she had a silicone implant, you might not be able to tell at all. And that's because silicone is more viscous. It's essentially a gooier sort of liquid. It doesn't just spill out into the body like saline would. A rupture is not an emergency, okay? It's a cosmetic issue, sure, but it's not a medical emergency. In the saline world, it does just get resorbed by the body. The patient may go see their plastic surgeon, but it's nothing harmful to them. And this patient actually already knew that she had a rupture. She didn't want to get them changed. That's why she got a mammogram. Silicone is a little bit trickier. If you're concerned about a rupture, you have to do an MRI. It's a little bit more complex for this talk, but just so you guys know that there's different ways that we basically treat implants. Lastly, I'm going to talk to you guys a little bit about image-guided procedures. So there's a few things that we do. The first most common one is going to be a biopsy, which is a small tissue sample that we send to the pathologist, and then we get the results in a few days. The pathologist obviously is the one who's looking at things under the microscope and telling us what it is. Our job is to make sure that we get a good representative sample of the abnormal area. I'll talk a little bit about abscess drainages, cyst aspirations, and then also something called a pre-surgery localization. This is where we're pinpointing a cancer for a specific surgery, a lumpectomy. A lumpectomy, and I'll go into this as well too, is meant to resect the least amount but correct amount of cancerous tissue. This is a picture of our tray, very typical of what we have. We use local numbing medication for all our procedures. There's no general anesthesia, no sedation. Patient can eat whatever they want. They can drive themselves home. So I consider a procedure, not a surgery, something that I think that most patients should know. So let's talk about our first procedural case. This is a 26-year-old who has a left nipple ring. She came in because she felt a lump under her left areola, her nipple. She got some antibiotics from her general practitioner, but it's just like not getting better. We do an ultrasound because that's the first thing you do when you're looking at someone who's young, who you think might have something called an abscess. An abscess is an infected pocket of fluid, okay? It's basically a pocket of pus. It's going to cause a lot of pain, a lot of redness or erythema, and it can also cause a bump as well too. Now, abscesses are important because when they're very small, your body can generally get rid of it, or at least it can do a better job of kind of maintaining everything. Once it kind of gets to a certain size, it can only make you sicker. It can cause your white count to go up. It can cause you to have fevers. It can cause you to become septic. So this is a pretty big issue. It's very important. And in this case, it's probably related to her nipple ring because it is like a piercing device that's going through the skin, right? So even if it was placed sterilely, it's always just going to have an inherent risk of infection. And that's what this is. It's an infected pocket of fluid. And as we can see here, we see this red stuff again. That means that this area is very vascular. So it's infected and is very, very angry. What we end up doing, and a similar procedure as a cyst aspiration, I won't show you that, but essentially what we end up doing is under imaging guidance, we put a needle right down to that abscess, and then this is what ends up coming out. So this is all the pus that came out of her abscess. It is pus and it is blood that is in this area. You can see it in real time. It's like this, and then it kind of collapses flat once we take out all this fluid. We can then send this culture to the pathologist so they can tell us exactly what kind of bacteria is in here. And that way we can get the most specific type of antibiotic to this person and help her get better. Lastly, I'll talk to you a little bit about pre-surgery needle localizations. Just some terminology here in case you guys don't know. A mastectomy is when a surgeon removes the entire breast. A lumpectomy is when the surgeon removes only the cancer, but they need guidance on where that exact spot is. The type of surgery somebody gets is dependent on a lot of things. Essentially, it depends on how big your cancer is and if it's gone to other parts of your breast. So let's say that there's like 3 spots throughout your breast that you haven't, you probably are going to get a mastectomy rather than 3 small lumpectomies. But if you're lucky and you only have a small cancer, everything else looks good, then why take the whole breast, right? We can take out just a small amount. The problem for the surgeons is that it's very hard for them to find this area, okay, in the operating room. So this is an example of a patient where we did biopsy. This is her cancer. This little rectangle here is a clip that we place during biopsy so that if we need to revisit this area, we can more easily find it. So that clip is something we place. It's obviously not something the patient has inherently. What happens the day of the surgery is that we do this under imaging guidance. We place a needle and a wire down to this exact area. That circle there is the wire, and right here is the wire that we put directly to that area. Then we send that patient down to the operating room, and the surgeon will use that wire to find exactly the area that they need to take out the cancer. The way I think of it is that if you're a surgeon and you are trying to find a cancer in the operating room, it can be very difficult because you're looking for which quadrant you have to go to, at what depth. You need to have some sort of guidance, and that's kind of our role as the radiologist. The surgical specimen is then sent to us. So the surgeon does her thing. She takes out the tissue, and then we actually take an X-ray of that tissue to make sure we got what we needed, the exact same spot. And this is why radiology is so cool. You can literally tell if this is going to be the right area. Remember a little rectangle, that little biopsy clip, it's there. So we know that we have gotten the right area that's been taken out. Okay. Well, this is what it kind of looks like in real life. This is, and these 2 bottom pictures, this is a surgical specimen with the wire inside of it. We take an X-ray and you can actually see the cancer pretty well as the clip. On this left side is the type of wire that's used on the pictures on the right-hand side. It's a different type of hook and clip, but it's exactly the same premise. So this is another cool procedure that we do for the surgeons as well. And I think that is all I have for you guys today. I hope you guys learned some stuff and I didn't either repeat too much, if you guys already knew a lot, but hopefully it kind of gives you an idea of what radiologists do and maybe a little bit more about breast radiology that you may not have known before. So thanks for joining.
Thank you so much, Dr. Chen. I think it was really, really informative. I know that at least I did learn a lot of stuff regarding your profession. So
Good.
what we're gonna do right now is just share the poll questions once again, um, just to make sure. Let's relaunch the polling. You guys can answer the questions once again, just for it to be like a little bit post-session sort of assessment. Okay, so we are getting lots of answers. I will be closing the polls in a little bit, so you guys can go ahead. You still have time to answer these questions. I will give you guys around 20 more seconds so you can answer all of them. And in 5, 4, 3, 2, 1, and hold. There are the results, Dr. Chan, for you to review.
So I can go over these very briefly, at least the questions. So, average risk women is going to be starting at age 40. Most of you got that right, which is awesome. We do require a clinical year in our residency. That's that intern year that I was talking about before. Invasive ductal carcinoma is our most common type. Invasive lobular is actually one of our trickier cancers, but I think it's like 10% or it's much lower than invasive ductal, which is the most common. A cyst is certainly considered a breast mass. So if you ever hear breast mass, don't necessarily panic. It's okay. Breast mass is just a 3-dimensional structure. Best way to image an abscess is going to be with ultrasound. We're going to see that most easily. And let's see, is used for all of the following, except we don't need to do it for patients with saline implants. So a majority of you guys got that right. Like I said, people with saline implants, if we want to evaluate it, physical exam is good enough. And then out of all of these, I don't know if I really went to this that well, but MRI is actually the only one that doesn't use radiation. The R doesn't stand for radiation, it stands for resonance, magnetic resonance imaging. So that's always kind of a tricky question. But MRI does not use radiation. It basically uses protons in like water, in your water molecules is the best way to kind of simplify it, but no radiation with that. So great job, everyone.
Okay, thank you so much, Doctor. So I believe we can go ahead and begin our Q&A if you are okay with that.
Of course.
Okay, so I see a few questions over here. Okay, so the first question we have over here is from Caroline. And they ask, how long do swollen lymph nodes typically last after a COVID vaccination?
That's a great question. So we usually don't necessarily worry about them until they persist like 3 months out. They can last for quite a while, and obviously our data is fairly new. But generally, after we notice it, we like to do follow-ups. We are, doing basically 8-week follow-ups currently, so 2 months, where we would look at that area again. And if it has changed at that point, Usually things will kind of be starting to die down by that point, meaning getting back to normal. If they still persist, we might still do another follow-up. But generally a few months is what we're seeing so far. They should eventually, though, start normalizing.
Okay, great. Thank you so much. So another question that we have over here is from Catherine. And they ask, they say, I went with my mom recently to a doctor's appointment, and she asked what age I should start getting a mammogram. I'm sorry. However, the doctor replied 45. I was just wondering if that was a new normal.
It's not a new normal. The problem with screening mammograms is that there are many different societies that have different recommendations. They're not too far from each other. Okay. It's not like one's recommending 40, another one's recommending 60. But depending on the guidelines that your PCP wants to follow, it could vary. Now, from our perspective as a radiologist, we see so many cancers between ages 40 and 45. So I'm always going to be a proponent of starting at 40. I don't want to miss anything that can happen between 40 and 45. I see patients even in their 30s with breast cancer. Other people, you know, the only reason why people would want to delay it is because of all the like anxiety and extra procedures and all this other stuff that you may have to undergo if you start a little bit earlier. But like I said, I mean, our job is to really catch cancers, and we don't recommend biopsies unless, you know, we have some suspicion. So if you ask a radiologist, it's always going to be 40. If you ask a PCP or OB-GYN, it could be 40 or it could be 45.
Okay, thank you. So another question from Catherine over here is, can you reduce breast fat if you lose any weight as well as size maybe? And can the size of your breasts change over time?
Yes, your size can change. And it's mostly going to be due to fat, because you can't really change your tissue density unless, like I said, you're taking like hormone replacement or you're breastfeeding. So anybody who, you know, has breastfed or has known somebody who's breastfed before is going to know that, you know, your size is going to increase during breastfeeding, right? So a lot of that is from the tissue itself. If you end up, let's say that you're someone who really wants to lose weight, you've been on this regimen, you're eating less, you're dieting, all this stuff, you can certainly lose fat from your breast, which ultimately is going to decrease your volume as well too.
Okay, thank you. That's very interesting, actually. So another question that we have over here is from Prisha, and they ask, can a hematoma start bleeding internally?
It basically is bleeding internally. That's how it develops. The most important thing is that we have to make sure it's not going to bleed anymore. Okay. So if a hematoma is increasing, then that means that there is still bleeding. But a hematoma by definition is caused by internal bleeding. That's how it even formed to begin with.
Okay. Thank you. So another question that we have from Prisha also is, could the silicone block any blood flow because of the viscosity?
So silicone, when it leaks out like from a rupture, it's going to not, it doesn't necessarily get into your blood vessels. It's still pretty macroscopic. It's pretty big. It actually can form what we call granulomas, which are little like clumps of silicone within the breast. And sometimes patients can feel it as well too. And interestingly, I think they still do it in some countries now, but they definitely did it in many more countries back in the day before implants were developed. They did what we call silicone injections. So these were not done by doctors. A lot of the times they were done by big people with like silicone and a needle. And they would just like inject your breast with like random spots of silicone. I think they do that for like your butt as well too. This is basically all for augmentation. Okay. So in those cases, you're basically increasing your overall volume of your breast because you're adding stuff to it. But it's the same scenario as if your implant had ruptured. You're creating granulomas or little clumps of silicone throughout the breast. This stuff is not going to block any blood flow necessarily. You're not going to embolize your silicone. Like your silicone's not going to go elsewhere because it's all pretty sticky and it's all contained together. Interestingly, it can get taken up into your lymph nodes, and sometimes we can see it in your axillary lymph nodes as well too. But I don't think there's been any studies where silicone is causing like a clot or anything like that. I don't think I've heard of anything like that.
Okay, thank you for that information. So Catherine asks over here, are pathologists the ones who actually determine if it's cancers or not?
Yep. Yep. They're the ones who, they can only decide, they can only come to a conclusion based on our tissue. So it's all really a team effort, right? Because we need people to be referred to us from their primary care. And then we have to make sure the pathologist gets the right tissue. So they're the ones who look at the cells under a microscope. They do different stains, and they're the ones who tell us if it's benign, a cancer, or something in between, which is called high risk. But they are the end all be all. They're the ones who decide whether it's something to worry about.
Okay, thank you. I believe this is a very interesting question. So Nicole asked, is imaging able to distinguish among different stages of breast cancer? You did mention that pathologists are the ones that determine if it is cancers or not, but can you see like different stages when
So
you do
yeah,
imaging?
if you're talking about stages, you're generally referring to if the breast cancer has gone to other places. That's how staging is generally treated, as opposed to grading, right? So the grade of a cancer, like grade 1, grade 2, grade 3, which is basically like how severe a cancer is in its own form. That's something that only a pathologist can really determine. I think we on imaging are able to suspect that something is going to be really bad, versus something that's like, okay, if this is a cancer, it's probably going to be like one of the smaller grades. In terms of staging is basically saying, hey, how big is your cancer? Has it gone to your lymph nodes? If so, which lymph nodes is it? Is it on the same side, the opposite side? There's actually a whole like table to it that we can definitely tell in imaging. That's the only way you can tell. It won't be with, specifically breast imaging. It'll be with something called a PET scan. So a PET scan is going to be a cancer study from head to toe, looking for other areas of cancer. And so that's going to tell you if your cancer has gone elsewhere. Let's say, you've heard of breast cancer probably going to like your bones, your lungs, your brain. So that's all stuff that's picked up on imaging. Yeah. So that's staging. Grading, where you're talking about that's more of like a pathological thing where you're talking about how many abnormal cells are there. That's pretty much a path thing, although we can kind of suspect it, but they're the ones who kind of decide on that.
I'm sorry. Thank you. I'm really sorry. I took the water. So another question that we have over here is from Kenneth, and they ask, what are your thoughts on computer-aided diagnosis with AI in regards to radiography? Could AI completely take over the role of a radiologist in the future with the speed of AI advancement, or would be a supplemental role?
So this is always a question I get with radiology. So we're always looking at ways that AI can make our life easier, okay, but in an accurate way. So I think that AI can play a role, a supplementary role, in very normal cases. Let's say somebody with very low density breasts, okay, very fatty breasts, and they can maybe pick up like any abnormal findings and make our jobs a little bit easier. Or if it's normal, be able to say, hey, it's probably normal. The problem is that the technology is just not there yet for looking at specifically what we do. So when I was in training, and I was reading lung CTs, there was a project where they were trying to develop an AI system where they could pick up lung nodules. Lung nodules, if you guys ever encounter them on imaging, are a huge pain to look at. They're very important, but it can be very cumbersome, and you have to like have a lot of coffee, and you have to really make sure that you don't miss anything, okay? So AI can help with like certain sizes. There's certain thresholds, for instance, but it's not good enough for patient care. That being said, I've always been kind of the belief that if you are someone who does procedures, that AI is going to very rarely take over your job. I mean, there's robotic surgery, certainly, that you may hear urologists talk about, and there's really advanced equipment. But if you're ever worried about AI taking over your job, just do a field where you have a lot of procedures. That also being said, I don't think AI is going to be taking over what we do anytime soon. I think it might make our job a little bit easier for more simpler cases. but we actually technically use some AI now. It's called computer aided detection, CAD or CAD. It's available on a lot of our stations, not just where I work, but elsewhere as well too. And basically it's a computer that kind of reads alongside you, and it puts like a little asterisk like in an area that it thinks may be abnormal. So just trying to like draw your eye to it, not saying that it's like, you must call this back or must call this abnormal, but just being like, hey, like, did you notice this area? It looks weird based on like our pixels. And I'll tell you from my personal experience that often is like a lot of false positives. There are a lot of things that actually are not problems at all. Just based on, I guess, their algorithm and the pixels and whatever they're using, it draws attention to it. But then when you ask like a physician, like a radiologist about it, it's actually not concerning. So from a personal perspective, I think there's a role for very normal studies in helping our workflow, but I don't think it's going to change what we do anytime soon.
Okay, thank you for your insight. I think it's very interesting. So this other question is a little bit more regarding your day-to-day life as a physician. So Caroline asks, how do you stay up to date with current medical literature, and what does ongoing training look like?
So we stay on top of it. Well, so being at an academic institution is very easy because we're always sharing kind of new information with each other. We have conferences, many different conferences, either for radiology or for our specific breast field that happen throughout the year. And people are always submitting kind of new research, things that they're discovering at their institution or in other countries or whatever. So that's a really good way of kind of hearing what's new and what's out there. On top of that, at this point, I'm not using textbooks as much. That is definitely what I use for med school, residency, and some of fellowship. But at this point, the basics of textbooks, I use every day. And now my job is to kind of get the more clinical aspect and the more obscure cases that textbooks aren't going to help me with. And in those cases, I'm using more articles. So we have something called like radiographics. So we have many sources. It's just one of them. But they're very good specific articles about a specific breast pathology or procedure or something that someone has encountered. And this is all online, and there's new stuff coming out all the time. So we do read that quite a bit as well too. In terms of continuing medical education, yes, we have CME credits that I think there's like a certain requirement that we have to have X amount of years out of training. And you can get CME credit by attending these conferences, going to certain lectures, and that sort of thing. So there's always opportunities, I think, to continue. It's definitely easier in the academic setting, though, because it's always on people's minds. And people are, I think, in the headspace to share with you new inventions or new ideas of thinking. So that's kind of also why I like academics, too.
Thank you so much for sharing that. That sounds actually really cool. So Saheen asks over here, what advice do you have for students that are seeking to receive enough shadowing and clinical hours to go straight into medicine right after undergrad?
Well, I'll tell you that I probably didn't do as much as I should have from my experience. Like, I had no idea what I was getting myself into. So like I have like one doctor in my family. He is, like my grandfather in like Taiwan, like we don't even like speak the same language. So he was like of zero influence in my life in terms of like career and that sort of thing. So, I think when I was in high school or maybe I was in college, I did shadow some physicians. I did the basics. Like I went to, it was a family friend, and basically I just kind of shadowed her, and she was an internal medicine doctor. I think, if you have a certain specialty that you are particularly interested in, either based on your research, based on your family, friends, TV shows, whatever, go and shadow like that person and see what your day-to-day is. If you have no idea, internal medicine or a family doc is going to be your best bet because they are really like the classic doctor. Of course, if you're interested in surgery, then you can always get shadowing experiences at hospitals nearby. Like, so just, I think you can message like volunteer services to even get the idea of what a hospital is like. I think I did that as well too. I had like a little uniform and I just went to different floors and like delivered like different medications and that sort of thing, because I'd never really been in like worked in a hospital before. So that was one experience I had. But other ones too, you can always message people that are working like at that hospital to see if you can get shadowing experience. That's going to be the best way to know what you're getting yourself into, I think.
Okay. Thank you. Thank you so much for that advice. Um, so I think this one's a very interesting question. So some members of our audience ask, is being scared of blood a problem as a medical student and a doctor?
Being scared of blood. I think that it'd be abnormal if you were okay with seeing blood all the time. I mean, that'd be, sorry, I have to adjust here. My computer's like getting low on battery here. So you're just going to see this awkward wire over my shoulder. Okay. No, I think that's totally fine. So when you are first starting off, let me put this way. When you're first starting off, you know, my biggest fear was actually gross anatomy, because we have to do cadaver dissections and sometimes you have to go late at night to do it and that sort of thing. Our very first cadaver session, I remember we were all talking about it. I think we had like lunch before and everybody was worried about it. So you're not the only person. I think at the end of the day, when I have non-medical friends who ask me how I'm not as grossed out by blood or by like throw up or like all these other like, typically gross things, I mean, I think a lot of it's just that we view it as like a science and we view it as a problem and we are part of the solution. As a physician, your job is to help that person stop bleeding, stop throwing up, stop whatever. So it becomes more of like a clinical sort of problem that you want to fix. I think that a lot of people in the beginning are afraid of blood, needles, whatever. And eventually you just kind of get over it. Of course, there are going to be people who tell you that they were never scared of blood. They were never afraid of doing a cadaver dissection. And that might be true. But I'm telling you from my perspective that it was totally normal to be like, oh, could I deal with this? Like, I'm not really sure. And I mean, I did a full year in surgery and I was like totally fine, because eventually you start thinking of like the human body as like kind of like a puzzle piece. Something is not working, something needs to be sewn up, needs to be fixed, reconnected, whatever. And then that kind of takes over the grossness of it. That being said, I mean, all of us have something that we don't particularly enjoy. I don't like eye stuff as much. I never want to do ophtho. I hated any time that somebody dealt with eye things like on TV shows. It really scared me. So then I stayed away from it. But things that are general, like blood or whatever, you will eventually get over if you're truly interested in medicine, and it'll be okay because people are going to see you as the source of help. And that I think is going to energize you as well too, to really be that person for them. So it's okay, is my long answer.
Thank you so much. I believe that definitely is relieving to many pre-health students attending this live session today. So thank you so much. Okay, so I think we have time for about 2 more questions. So one of the last questions is, can you talk about your shadowing experiences that you had in high school when talking to med school admission officers, or should you just stick to shadowing in your undergrad years, such as being in a program or hospital? Is this okay to put on med school applications?
Oh, I see. I think that if it's medical related, it's okay to include high school stuff. I think if it's something that happened in your life that is directly related to you wanting to be a doctor, or that has contributed to your experiences that is pushing you in this direction, I think it's okay. I don't think that you necessarily need to talk about high school like journal activities or like debate club or whatever, because that's kind of showing that like you don't have anything in college, right? That you can talk about, because if you did, you wouldn't have to talk about high school. However, if it's medical stuff, I think that showing that you've been dedicated to this for a while, I think that's totally fine. I mean, if you were like in middle school and like, you had some like crazy experience that made you want to become a doctor, that's like pretty important too. And you shouldn't knock it just because you were younger. So I think if it's medical related, it's okay to talk about if it's high school. If it's non-medical related and it's more about like rounding yourself out or showing your extracurricular activities, then I probably wouldn't talk about it as much. Because the higher up that you go or the more advanced that you go, you should be talking about more current stuff, if that makes any sense.
Okay, wonderful. Thank you so much. So for our last question is, do you have any recommendations for burnout within an academic standing, and what helps you? How do you balance your work life in the most efficient way?
Well, I'll tell you that work-life balance was really hard as a trainee. Anybody that you talk to is going to agree about this. And certain residencies are definitely worse than others. Some fellowships are worse than others. So it's not right to say that they're all the same. But essentially, you are all going to be getting paid very little and working very hard and having everyone expect everything out of you. For me, the way I got through it was basically support. So I had a lot of good friends. I mean, from college as well too, but from medical school, I had a really good group from medical school. And if you guys end up going to med school, I would advise that you find a good, solid group of friends, ones that are not going to backstab you, ones that are not going to judge you, ones that are like, just in it with you, and you're going together, you're growing together, and they're not going to be jealous of your success. They were the people, and I still am in touch with most of them because a lot of them are in LA with me. We're all doing different things now, from medicine to ENT to palliative care. And I think that's what really got me through this entire experience, because I always want to know that like somebody else was like suffering with me and they were like doing okay too. Like I'm one of those people who, like, if I'm the only one doing it, I'm like, oh my God, like what am I doing here? And like, what am I doing wrong? But if I see my friends doing it and they kind of look at me for support, I'm looking at them as well too, then I'm like, okay, we can do this together. Like, it's totally fine. That being said, one thing I do always want to emphasize during these talks is that I think you should never lose sight of the hobbies and interests, non-medical, that make you happy. It's very easy to get lost in books and tests, and you should, because at the end of the day, it's your test scores and your evals that are going to get you to the next level, right? But if you're able to maintain that and also keep up all the hobbies, interests that you have, I think you're going to be a better person because of it. There were many times throughout training that I had to put some of that stuff aside, which I think is totally normal. Things take a backseat, and then you kind of regain that interest as an attending. But I'm glad that I never really lost sight of all that, and I think that helped prevent my burnout. You work hard, you play hard. When you're studying, you put your mind 110% to it. Like, and that sounds so corny, but it's really true. You have to be able to compete with like the smartest person in your class. But when you're not studying and you're done with your tests, go live your life and go recharge so that the next time that you need to study, you're not going to be burnt out, So I compartmentalize. I would work very hard. And then when I was done, then I would relax, I would party, whatever, so that when the next round comes, you're like, okay, I'm rested enough. And I think that's really important for most normal people. There's going to be people out there who don't need to relax or party or do anything, and they are just like machines. And props to you if you're a machine, but I'm just a human. So I had to really balance both. It's definitely possible. If I can make it, you guys can make it too. The end.
Thank you so much for your advice. Now I will be beginning with our wrap-up presentation. So I want to thank you again so much for your presentation. It was very, very informative, and I know I did learn a lot, and I hope a lot of our audience members did as well. So considering this, I want to invite you all to reflect on the session today with these two questions that we have over here. So what brought you to the session today? What are 3 major takeaways that you got from it? And what do you want to learn more about? You can definitely just answer those in your mind, just write them up. And if you do write them, we want to highlight that the writing or reflection is not required, but we encourage you to submit it to our website for publication, for recognition of your hard work, and to enhance any future applications. I would also like to mention once again that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research in a plethora of topics, fields, and locations. I want to highlight once again that this program is 100% remote. So it gives you a chance to connect with absolutely anyone. It is an 8-week program that will begin on June 21st. So mark your calendars and agendas. For more information, you can fill out the interest form that was sent in the chat, and we will get back to you as soon as possible with any additional details that we may have. If you want to learn more about pre-health shadowing and how to get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion as well. We are also accepting team member applications if you want to take on a more active role in PHS to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able to donate, that you please consider doing so. It costs a lot to keep our program up and running and free to all of you. So if you are someone who can afford to, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you spread the word about pre-health shadowing to reach as many students as possible. Now for the part we have all been waiting for, that is earning a digital certificate for the virtual shadowing hours from this session today. So the first thing you're gonna do is go onto our website, find our professionals course pages, in this case, Dr. Chan's course page, and there you will be able to take our quick 10-question multiple choice quiz based on the content from this session today. You will have 30 minutes to finish your quiz. And we know that sometimes technology can be difficult. So for this reason, we'll allow up to 2 attempts to take the assessment. But if you run into any difficulties, please do not hesitate to contact us. To ensure that our website does not crash from a high influx of students, we recommend waiting around 30 minutes to an hour maybe after this session to take the quiz, which will be open indefinitely. And finally, once you have passed, you can click the finish course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. If unfortunately you missed a part of this session or you want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for these as well. Be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming sessions and events. We are currently booked every weekday through the rest of June for virtual shadowing sessions, so we definitely hope to see you guys over there. Once again, thank you all for joining us today, and please do stick around if you have any questions, and myself and other team members will be happy to answer them. This shadowing is officially over, and I invite you all to log off. Have a wonderful day, evening, or night, depending on where you are.